Thanks so much, Lydia. I'd like to say that I'm actually on Gadigal land tonight, and very pleased to be able to introduce Julia Thompson, who's got a very impressive bio, I must say. She is a very experienced consultant neurologist and obviously a fellow of the Royal Australian College of Physicians. And she's had a lot of training both in Sydney and in the UK. And particular interests she has are things epilepsy, autoimmune neurology, neuroimmunology, neuro-oncology, acute neurology, headache, and lots of other general neurology areas as well. So she's on the as a committee member on the Australian and New Zealand Headache Society. So we actually do have an expert talking to us tonight about headaches. And she is a local neurologist. She works at the Chris O'Brien Lifehouse and also at Prince of Wales Hospital. So many of you will probably know Julia already and be able to refer to her. She's also, which is one of my passions as well, improving access to specialist services across Australia. And part of that is working in Tamworth, New South Wales, and doing telehealth. So very welcome, Julia, and I'm really interested. Headaches is such a bread and butter subject for GPs. And particularly, we're all so concerned about TTS and headaches after vaccination. So we're really interested in finding out what you can tell us. Thank you so much, Julia.
Thank you very much, and welcome everybody. Hopefully not too dry a talk. We'll try and make it as interesting as possible, but neurology version of interesting doesn't always ring true with everybody else, I appreciate. So tonight we thought we would do a nice overview of some of the key areas in neuro-oncology and autoimmune neurology that we get a lot of questions about. They're not actually the most common things we see, but that's fortunate, of course, but there's certainly an interest area, an area a lot of people feel unfamiliar with. The other thing we'll go through as well are key headache cases in 2021, because of course headache has not only been popular pre-2021, but has become a lot more popular recently, particularly with GPs in accident and emergency asking and referring a lot of questions. So it was a reasonable opportunity to revisit a few old favorites. So without further ado, I have no major disclosures, and all my research is actually funded by Oxford University and the Wellcome Trust. And to date, no research has been funded by drug companies. And what is neuro-oncology and autoimmune neurology? So of course, it can encompass the cancers themselves, but this is not oncology. This is more an area of symptoms of the malignancy, which of course can vary depending on the malignancy, but also the symptoms of the chemotherapy, the immunotherapies, radiotherapy, CAR T cell, things like that, and symptoms of neurosurgery, because of course a lot of the surgery for the different cancers can lead to side effects. The key areas, of course, seem really obvious, which would be epilepsy as probably the lead, followed by headache, pain, neuropathy, and down the bottom, but still really interesting, the autoimmune and paraneoplastic conditions. And this is also the area that we've done a lot of research in. So case number one, now this is a real case, although it's my case from 2017, but it's quite classic. It's something that is not decided to trick you, but it's actually something that you can see in the community and in hospital, and is something that was often missed, but more and more is being picked up. So a 22-year-old girl with new onset hallucinations and psychosis was actually having difficulties with her relationship, seen by psychiatry, thought to have psychotic depression, but they weren't quite sure that it fit clearly with a recent breakup, but there was a strong family history of depression, and that's what they thought this was going to be. She was sent home with family. She took a leave from university. She was otherwise well beforehand, and her MRI and EEG on her presentation, and this was ordered by psychiatry, was reportedly normal. She then presented 1 week later to A&E, and radiology referred her to us, would you believe? And radiology called neurology service because of the following, where she'd been referred to them from A&E with this exact statement, and she was cowering in the corner near the CT scanner and believed she was a velociraptor and was actually trying to attack the staff. So this is where psychiatry came down and said, it's not organic, which is our favorite word, particularly when most of the human body turns out to be organic. And basically psychiatry and neurology, of course, took over care. And she had positive NMDA and CSF and serum, as you're probably all wondering. Her EEG was not repeated because of a patient compliance issue, but later turned out to have some of the characteristic features. Her MRI showed some subtle changes in the medial temporal lobe, and this is an area, of course, that can show for a number of things: HSV encephalitis, viral encephalitis, seizures, but also autoimmune encephalitis. And her CT chest, abdomen, and pelvis, which was performed because of this question of potential malignancy, showed this. And that's the problem area. And to make it really easy, that's a tooth. So this is, of course, a teratoma. And this is a key association with the NMDA receptor positivity, which is, of course, teratomas, particularly in the ovaries. So I bring that case not as a surprise, but to remind you all that this is not a new topic. And in fact, it's really old and first came about in and around encephalitis lethargica and started to be recognized after the 1919 flu pandemic. But it was around before then, but it's going to be like long COVID when all of a sudden something comes more obvious to us and thus leads to research and increased recognition. But it's been in the media, and of course, the movie and book Awakenings focuses on NMDA encephalitis. And there was also a lot of movie and book press for something called Brain on Fire, which again looks at autoimmune encephalitis. But it's bringing to the press a rare condition that actually, though, is often missed, and it can then lead to permanent disability. So the incidence, of course, is low. I really want to stress that these are zebras. These are very interesting zebras, but fortunately, they are nowhere near the 1 in 5 to 6 stroke risk in Australia, the 1 in 7 migraine risk, or the 1 in 26 epilepsy risk. They are 2 to 3 per million, and the majority are not tumor associated. They are associated with an autoimmune condition, often post HSV encephalitis. But that's always interesting because, of course, spring is the greatest season for that. The median age is 21, the youngest 2 months, and it is seen in kids and can be associated, of course, with a movement disorder. In younger kids, it's known to be more associated with cancers, and that's when they really push to go for ovarian teratomas and other tumors. But in under 12, it's exceptionally rare, and in over 45, it's most likely post-infectious. It comes with flu-like symptoms, and to raise this is because a lot of these autoimmune encephalitides do. They headache, flu-like symptoms, they may feel hot, and they may not even have a recorded fever at the time, but can progress then quite quickly to psychosis, anxiety, insomnia, memory problems, and then potentially seizures and other things like that. However, of course, early on, it's going to look a lot like other acute onset psychosis or acute anxiety, but the key is it's disproportionate to everything around it. The syndrome is responsive to immunotherapy, and a lot of the autoimmune ones, time is brain, because early on with steroids treated early, the patient has a chance for complete recovery. But the longer you leave it, the more T-cell related mediated damage there could be, and the person may not actually reach a complete recovery. They do not, NMDA patients do not tolerate antipsychotics well and actually can develop neuroleptic malignant syndrome. And this is what was seen in the movie, of course, Awakenings, where these patients were treated with antipsychotics in psych hospitals and then developed these secondary complications. And it was only when given dopamine agents and Parkinson's medication did they clue in that perhaps something was different. And this magic cure they were given was steroids, good old-fashioned steroids. Now, time is brain, and the reason to present this again and again is that LGI1, NMDA, all of our different research is time is brain. But in cancer hospitals, these presentations present usually before we've found the cancer, if the patient is not on treatment. And that second bit will lead into the next problem. But these conditions often appear before you found a cancer. So if you've got someone in the clinic where it doesn't add up, the person doesn't normally get depressed, they're not themselves, there's no particular reason they're coming with any neurological features, seizures, and other symptoms, it's important to actually question whether, in fact, this could be viral encephalitis or autoimmune encephalitis, particularly if it doesn't add up. And new onset psychosis, of course, in someone in middle and older age is not something that we commonly see outside of dementias. And also in younger ages, out of the blue with associated neurological symptoms, again, would be concerned. And this is often a very dramatic, but an often MRI finding, but this is actually from HSV, because this is your #1 linked virus to NMDA. And it's because the NR1 subunit is actually the same, and it's a cross-reactivity problem. So it leads to one of our big areas for investigation, what a lot of people are referred for the question of, what is a paraneoplastic antibody and does this person have a paraneoplastic syndrome? Again, fortunately or unfortunately, depending on how interesting, this is of course rare, and it's important to say it, but it's important also to bring it up because it's often missed because it's not thought of early on. They are associated with malignancy. Paraneoplastic antibodies, though, are not normally the cause. They are association antibodies, but 40% of the syndromes, and the classic syndromes are well defined, may actually be antibody negative, and that shouldn't deter you. If someone has almost a classic syndrome that is paraneoplastic, then the key is to go looking for the cancer because the antibodies are simply association. Whereas with autoimmune antibodies, which are more the extracellular ones, they tend to be pathological. The problem with the paraneoplastic antibodies is they do poorly with immunotherapy. Why? Because the antibody is not really necessarily the problem. The problem could be something else altogether and is driven by the cancer. Association doesn't always mean cause. So the key is to look for the cancer and keep looking because often it's only one cell big. This is a busy slide on purpose. This is in order to show the problem where the tumor, of course, leads to this activation, and then both B cells and T cells are involved. And the antibodies aren't always the main players. The T cells are often the problem. So it's very important when we actually are directing therapy to not forget about T cells. And that's also to be said for our autoimmune immunotherapy. But this is even busier, again on purpose, because imagine sitting in clinic and you think, gosh, do they have a paraneoplastic antibody? And as you see, there are a lot. And day in, day out, you would not expect people, registrars, consultants, neurologists to just list them all off the top of your head. Classic syndromes, yes. But instead, it's more about, does the person have something that doesn't add up? Do they have a funny cortical syndrome? Have they have an encephalitis? Have they got new onset fevers and seizures out of the blue? And of course, seizures should come on in early 20s or they should come on in older age group. Also, obviously, pediatric, but they shouldn't just appear in middle age without a provocation. There needs to be a bit more questioning. There are classic syndromes like stiff person syndrome. Myasthenia can also, of course, be paraneoplastic, and people shouldn't ever forget, of course, thymoma. But this is an intentionally busy slide to show you that there are a lot of different conditions like this. And at the end of the day, a lot of different cancers as well. And it's about then going step by step, but also referring if you just think the person has something that doesn't add up, where they don't have a clear-cut psychiatric illness, or there's neurological symptoms with a psychological illness. And that shouldn't really be the case, of course. Now, of course, functional illness is an overlap to this, but that's okay. We have functional clinics and it's still bread and butter neurology. Now, this is the key. The intracellular ones, the paraneoplastic, are just an association. But the cell surface one, these are where steroids need to be given early, and they can be paraneoplastic, but they're often autoimmune. And this is where they could be an autoimmune response to a virus, autoimmune response to a cancer, autoimmune response, even to COVID, we've seen a heap. But the reality is they're the ones that will be treated well with steroids, and the intracellular are those that would be treated better with finding the cancer and the T cell immunity. Intracellular, busy slide again on purpose, but included in your slides to show that these are those that are usually cancer associated, but not pathogenic. And it's so that you in your slides have a basic overview of those that you could look at when you get the antibody dilemma, where someone's had a test, you've seen us order something complex, the patient comes back and says, what's this one? And of course, you don't know, and even we don't often know what the relevance is, because you might have ordered it thinking you've got one in the panel that's going to come positive, and a whole different one comes up. And can you ignore it? That's the next big question. And the extracellulars I've included as well, because of course they're the key to really recognizing early, because these are usually autoimmune, have a variable malignancy and often low rate, to be honest, but you need to treat early with steroids to avoid long-term damage. And I actually added to this year, of course, are those with LGI1 and Caspar-2, we also know cause a lot of neuropathic pain that is steroid responsive. And a lot of those previously undifferentiated paraneoplastic and autoimmune pain syndromes are also in this category. So this is the antibody dilemma. And we get these antibodies all the time because unfortunately in day-to-day practice, these come as a panel. In previous times, we could test individual and we could test on whole brain specimens, but now the easiest thing is writing limbic encephalitis panel or autoimmune neurology panel, and you can get then unfortunately all of them back, and then something comes up positive you weren't expecting. So that's where you actually go, I've got an antibody of unknown significance, what do I do about it? And go back to the patient, and do they have these features? Do they have autonomic dysfunction? Because that is obviously a key of a lot of the limbic encephalitis. Do they have an MRI consistent with it? Have they had seizures, cognitive change, CSF findings? And of course, always do CSF. This should be done anyway on anyone with new onset psychosis, because of course it's one of the panel to exclude neurological cause of psychosis before they're under the psychiatrists. Facial dyskinesia and facial brachial dystonia, a rare but well-differentiated condition associated with LGI1 antibody, and it's classic pathognomonic and treated easily with steroids. Malignancy, so of course if you've got the antibody and they've got a known cancer, that makes it really easy. And the psychiatric symptoms don't actually score as highly because, of course, psychiatric symptoms can be quite broad. And the number of times you'll see low positive VGKC or NMDA, serum usually, not CSF, and you have a patient who's got long-term schizophrenia, that question will come again and again and again. And that alone is not a connection. And viral prodrome, of course, because a lot of these look and smell like an early virus, but of course it's the encephalitic picture, although autoimmune. So this is then what we see more in the cancer hospitals. The 72-year-old farmer with a background history of diabetes and hypertension who has non-small cell lung cancer, which was resected in 2019, had no metastases and was seen at review 2 months ago. He's an ex-smoker, still drives, still working on the farm. For 4 weeks, has painful numbness in his feet from his new shoes and now stumbling, and the shoes are actually rubbing on his ankles when he's meetings. He has reduced sensation to his knees in all modalities, consistent, of course, with the peripheral neuropathy, and the Romberg's is positive, consistent with the sensory neuropathy. The nerve conduction studies, of course, are very similar, and he complains of pain throughout the exam, very reminiscent of the painful sensory neuropathy. And painful sensory neuropathy without motor features is a big red flag. That would always lead to us calling a neurologist, calling somebody, because that is your classic of potential autoimmune, potential malignant, but always bad. Always think a painful neuropathy where they don't even want you to go near their skin is bad till proven otherwise. Brain MRI and spine MRI was normal, and vasculitic 3 normal. CSF was otherwise pretty bland. So the big key bit, he's on nivolumab. Now, nivolumab, as we'll get to, is one of these new immunotherapies that a lot of patients have been on now for a number of years. His blood showed positive anti-Hu, and for those who don't know, this is otherwise nicknamed ANA1, which was not present previously. And it was diagnosed with paraneoplastic syndrome brought on by these checkpoint inhibitors, the nivolumab. So he was commenced on steroids and IVIG, and the question was raised by the patient to the GP. Do I keep going on my nivolumab? So this will not be uncommon, unfortunately, in the modern era. Chemotherapy. Chemotherapy actually encompasses a few things, and I'm not going to go through the TKRs, the conventional chemo, but conventional chemo causes most of the problems. It is otherwise dose-related poison. So of course, nerves don't particularly like it, bodies don't particularly like it, but conventional chemotherapy as well as hormonal therapy leading to headaches, that would be our large majority of side effects. But the new agents, the checkpoint inhibitors, of course, have led to a lot of new emerging autoimmune and paraneoplastic concerns. So 2017, they were released in Australia en masse, basically, and there's more and more every single year. And they were very important for cancer because now you actually have medications that help to manipulate your own immune system. And how do they do this? Well, Pd1 and Ctla4 are the main 2 types of this directed immunotherapy. And what this does is normally these are markers of self-reactivity. They're expressed on T cells that are highly autoreactive or on self cells. these antibodies do not attack the tumor. So the big thing is that people often get concerned, patients also, that nivolumab, pembrolizumab, these immunotherapies are attacking their tumor. They're not. They go in and they keep these cells alive. They keep your autoreactive cells alive, including those that attack cancer. Because after a while, there's fatigue, immunological fatigue. If your immune system is attacking a cancer, it can't kill it. It then says, oh, maybe I'm attacking myself, and it downregulates. What we're doing with these is keeping those cells alive. But unfortunately, we're also keeping any other self-reactive cell alive, whether autoimmune, whether paraneoplastic, even if you didn't know they were there in the first place. Depending on the studies, and in earlier studies, the number was small, but as we use these more and more, and as there's more recognition and survival in our patients, up to 14% of patients suffer from neurotoxicity, and it's even more for cardiology. The brain is special normally because the drugs themselves can't affect the blood-brain barrier very well. So a lot of patients, of course, aren't on these or aren't on these alone if they have cerebral mets. The problem is, though, these drugs can affect the barrier by getting these cells to go in there. And that's unfortunately where a lot of the neurotoxicity occurs. So these are the main problems that we deal with. To be honest, the biggest one, and the one we see the most common, it relates to tremor, relates to encephalopathy and delirium, but also the Guillain-Barré-like syndrome, where it's a painful AIDP pattern, can also lead to CIDP, but unfortunately, myositis is common, polymyositis, encephalitis, when antibody you didn't even know they had pops up, and then, of course, these latent paraneoplastic syndromes, where beforehand, when the cancer was there, the immune system hadn't created this, but with a little bit of enhancement from these immunotherapies, out pops a new problem. And they're up to 14%, and concerningly, they could be higher, but we're not checking, unfortunately, for things like hypophysitis well enough. We don't always look for optic neuritis necessarily, so it's important to be vigilant with all patients to going through all their systems in between appointments. Now, 45-year-old woman, this was this year, non-small cell lung cancer with cerebral mets, and she had a stable tumor burden. She was managed with radiotherapy and pembrolizumab, still working, had a first dose of pembrolizumab 10 days prior to presentation, was feeling well, quite positive about everything, and her gross neurological exam was normal, everyone's favorite word. Bloods were normal, CTKUB negative, but we were discharged home with analgesia, but kept coming back to A&E, going up a terrible back and flank pain. And they kept saying, okay, it could be kidney pain, we can't find the stone. Then she came back on the Friday, and of course it was Friday at 5, and we all remember the case because it was 5 o'clock on a Friday. And ultimately that seems to be when all things present to A&E for some reason. And the oncology team were called because she was ataxic, mildly confused, had symmetrical lower limb weakness with no reflexes. Her cranial nerve examination started okay, but 6 hours later, she had poor left eye closure, and then developed bilateral face weakness by that evening at 7 p.m., all in that same day. And an urgent scan was performed. And even though she was presenting with this AIDP picture, of course, these antibodies don't just decide to choose one place. And hopefully this will work. And as you'll see, known metastases, of course, that bit's not the surprise. But as we go, you'll appreciate, as it comes up, the degree of edema around these, particularly the temporal lobes, as the immune system had waged a war. Because by getting that kick from pembrolizumab, it was attacking everything in sight. So the LP wasn't safe to do because there was far too much swelling, unfortunately, and the exam was consistent with AIDP. But the key with these syndromes is to hit hard with steroids. Now, we don't normally do that if everyone's treated Guillain-Barré recently. We give IVIG, and we tend to then not give high dose steroids unless they've had this background. And with this background, we need to couple it with both, and we need to give a sort of long, prolonged taper of the steroids. And certainly, patient improved, and was treated with immunotherapy, but the big thing is that they cannot continue on any of these agents. And the reason is that if you re-challenge them, of course, it's going to be a bigger and better problem the next time. Then it's important to then look at different agents. And it's even worse with the combined Pd1 and Ctla4 agents, which are the newer, bigger thing of 2021, unfortunately. The big thing in the community too is to remember to really wean slowly with the steroids. And if the relapse rate is so high, but even if you've gone down a little bit and you're worried they're relapsing, to go back up on the steroids. And it's different to the classic GBS, different to the classic myopathies. This situation, steroids are our favorite drug and should be given for as long as needed. So paraneoplastic events, they need to basically, with all of these patients on this immunotherapy, anything that looks like a paraneoplastic syndrome, we routinely perform these tests on them. And even the oncologist will do these routinely every 6 months or so. But if any worsening, you really have to weigh up ceasing the agents. Sure, we do couple them sometimes, and you'll see patients with a tremor with steroids and we keep you going with the medication, but it really depends with what they have, and they need ongoing close follow-up, because once you've kept that antibody alive, the immune system is not going to get any signal to stop it, and it will keep going and keep going. This is why the steroid wean really has to be prolonged, and given the potential lifespan of the patient, it could literally go till they need to cease it in a different way. We do need to do this in these patients compared to the other patients where we're worried about long-term steroid side effects. In this case, we're not as concerned, because an important side of this is to suppress the second problem. So there are thousands of more things, and I could bombard you with scientific minutiae, but the big take-home messages of this area is, fortunately, to start with, that it's rare. And the next bit, that they're often missed. So although rare, and you think, phew, the biggest problem we face is that they get missed all the time. And they are missed because the patient's not sure what to present with, or they don't even present. And so it's something where it's important to have a shared team approach with oncology, GP, neurologists, all of us, whenever patients are on these medications, or with GP, neurology, psychiatry, if you've got a patient who's got something new, weird and wonderful, and it just doesn't add up, particularly as if someone, particularly a general practitioner, has a more lifelong understanding of the patient, then the bigger thing is that they will know when it doesn't fit. Whereas the rest of us, if a patient just rocks up to A&E, it can be very difficult to actually work out a time frame. But common things happen commonly. Dementia, schizophrenia, drug use, epilepsy, diabetic neuropathy, I promise, and functional illness by far are more common. And even though these are the niche areas we do our practice in, we are also at a cancer hospital. So we're really seeing the subsect of these patients. Whereas in day-to-day practice, in general neurology, fortunately, these are rare. We do look for them, but the other conditions are much, much more common. And stroke is currently 1 in 5. So put that at the top of your to-do list. Immunotherapy can lead to a lot of neurological side effects, and it's important that, and the big take-home message we tell our registrars as well, is look at the CK and look at the heart, because the heart is one of the favorite places for autoreactive antibodies, but it's often missed. Whereas we can see the neurology, we can often see the change in status, that the patient's weak and other things present more obviously. We can see on the blood tests, the liver, we can see the blood tests, the muscles. But whenever you've got a complication for neurology, go looking at the heart. Whenever you've got a complication, even the eyes, go looking at the heart. Because unfortunately, the troponin might be leaking up, the CK might be leaking up, there may be ECG changes that we're all missing. But of course, these autoreactive antibodies are going to be present and difficult to control. And don't forget the horses, conventional chemotherapy. So the big things you will see: hormone receptor blockers, headache, 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 particularly post-breast cancer, headache, cognitive fogging, heightened pain, feeling pretty dreadful and tired, tired, tired. Chemo brain, it's a thing, patients have it. unfortunately, it's a struggle and it needs multidisciplinary team. Patients will complain of it. So too will patients post-COVID. They could all sit there and complain together very happily, and that'll be very justified. But it does not need to be ignored. It is something that's quite important to address. Radiation brain's a thing, and funnily it gets missed, and probably because it has a lot more cognitive effect. So the patients probably aren't telling us about it, but it's something to add in there. Chemoneuropathies, these are actually well picked up and the patients are prepared for it. So with conventional chemotherapy, patients usually know what's coming. The big thing though that patients are not told is that your conventional neuropathy agents, the NDEP, the Lyrica, they don't do anything for this. The chemotherapy-related neuropathy is better treated with duloxetine and other agents. And there's very good long-term evidence that actually your conventional agents for neuropathy aren't how you should be treating chemo-related neuropathy. Radiation, cognitive changes, we mentioned, headaches, many different reasons, pathology, surgery, drugs, epilepsy, also steroid myopathy. Of course, dexamethasone gets dished out like lollies for all the regimes. And so after a while, a lot of patients are coming, they've survived everything, but come with quite a significant myopathy. Vasospasm and stroke-like episodes occur a lot of the time, particularly when patients are on their take-home infusions with Folfox and Folfiri, and RCVS, which can of course occur with any of these medications. But always don't forget the underlying disease as a potential cause. And that's, of course, a really big part of this, that, of course, cancer could just be leading to their side effects. And we get a lot of patients who come and go, I've got a headache, I've got pain, has the cancer come back, etc. And it has, and it's a problem with bony mets, etc. Now, a lot of the time that's picked up already on the routine scan, but it's still something to always take seriously because scans are only done at intervals. And of course, it's in between that the patients might be seeking attention. So then we go into part 2 and the real life problem for 2021 that is the last few months for everybody. Now, not a big problem for us because I suppose this is bread and butter, but we do notice that there is an increased presentation, mostly patient-driven, with headache, which you can all guess why. But the other advantage is it's a good opportunity to revisit the actual reasons that patients are presenting. So all these cases are actually real cases from the last 3 months, based on my on-calls or based on patient referrals. So none of these are designed to trick, by the way, but these are literally taken from notes. 25-year-old woman, only regular medication was the contraceptive pill, which was started 3 months ago. Lives with a flatmate, social alcohol and smoking only. Mood is generally good. She's woken from sleep in the blue with a severe headache. She's not a headachy person, so this really distressed her. Her right arm felt heavy, although she wasn't sure if it was weak, and it was certainly numb compared to the left, but she wasn't really sure if it was numb because there was lots of tingling with it. She couldn't get back to sleep. Her headache was about 9 out of 10, according to her. She took Panadeine Forte that she had at home, a few tablets anyway, and the headache continued very unchanged. She's not a headachy person, so her first step, of course, at 3 a.m. was to front to hospital. She was photophobic, had mild meningism, and she was personally worried she had meningitis. Her pain was worse with position, and she had nausea and dry retching, but no vomiting as such. So this is a good chance to point out the obvious. She comes with red flags, and red flags, I don't care if all A&E start with is I have a patient with red flags, because then you're like, you've had me sold, what have we got? And the reality is that whether they present to the neurology clinic, the GP clinic, or A&E, these need urgent attention. Sure, the majority of patients with some of these problems, it's going to be migraine. But you have to always take it seriously before de-escalating it if anyone presents with the red flags. The number one thing, of course, is the systemic symptoms or secondary diseases. Now, this is easy because fevers, chills, night sweats, you're thinking, yep, meningitis, things like that. Neurological symptoms, that can, of course, be with migraine, but that is very diagnostic exclusion. So any neurological symptoms and signs we have to take seriously. The onset. Now, the onset thunderclap means literally it happened immediately. So the person was there and it went from 0 to 10 within seconds to minutes. Not it felt the worst ever, but when you actually tease away the patient, like, oh yes, it just was really bad. It came on over an hour. No, it literally hits them. And you can even see some patients fall over. And some patients, particularly those when an aneurysm has had a leak, it describes to them that they've almost felt like they were going to collapse because the pain was so bad, but they felt so generally weak. Older age, so when a new headache is new onset at an older age, it's an abnormal thing. Migraine doesn't come on for the first time above the age of 50. Positional, so yes, things like migraine and cervicogenic headache, of course, they're going to be worse when you move your neck. But we always have to take it seriously if the person's headache is worse lying down, gets better standing up, or if they cough, sneeze, etc., and they're clutching their head. Prior history, so this is important, where if they've never had headache and out of the blue in comes a new concerning headache, it has to be taken seriously, particularly if it's not a really classic migraine or tension headache presentation. Pregnancy, we always take seriously. They have us at the word pregnant. Yep, migraine wins by far, but we don't ask questions. And precipitated by Valsalva. Again, cough headache, sneeze headache, cervicogenic, most common, but we have to exclude the most serious. So this is an example. I didn't put her image because I haven't got her permission to share it, but this is an exact example of what she presented with, which is, of course, a cerebral venous sinus thrombosis. And I put her case in on purpose, not because it's rare. Actually, of course, isn't that rare, but it's rare for some causes. It's not rare for the oral contraceptive pill, particularly the older oral contraceptive pill preparations and higher doses. It's fortunately rare enough that most people have a migraine, but it's something that we see, and we do a lot of venograms, we do a lot of assessments for cerebral venous sinus thrombosis for multiple causes at the A&E level. And the big thing is the headaches, decreased an altered conscious state, the altered vision, nausea, vomiting. Most of them have any of papilloedema, cranial nerve palsies, focal neurological deficits, seizures, or coma. And the headache is not mild. It doesn't go away. So some people go, oh, I had a bad headache, but then I did some exercise and it got better. Then it is not this, clearly, because these are warning system headaches. This is your brain screaming at you that something is very wrong. So then it doesn't go away with Nurofen or exercise or sleep. This is something that will break through that. And this is why we need to do the tests. And the causes are numerous. So of course, infection, illness, malignancy, oh my goodness, hormones, and then also people born with prothrombotic conditions they didn't know they had, or that they were born with a risk they didn't know they had a vaccine and unmasked it. And then of course, 12% are probably idiopathic, and we don't know the cause, but they likely had an underlying thrombophilia that we just didn't know. And the investigation for these, the bloods, including thrombophilia, screen for your conventional CVST, and I'll revisit why I said conventional in a few cases' time. EEG could be done if there's any risk of seizures, but the main thing, of course, is CT brain or CT venogram, or if it's an outpatient and you're sitting on the fence, a young woman, and you're not sure that it's actually a CT venous anomaly, then you can do an MRI MRV, but it's not quite as good, of course, just from the way the gadolinium will be picked up. So the best one is still CT brain, CT venogram. The treatment, anticoagulation, because of course, think of it like a DVT of the brain, and it's treated as such. There is no, yes, there's associated bleeding, but that's from the pressure forces of the fluid around it. Analgesia and anti-epileptic agents are often both needed, but we only start the anti-epileptic agents if there's been some kind of seizure or seizure-like activity. We don't do it prophylactically due to the risk of the drugs, but analgesia we're often giving in truckloads. And then you remove the precipitant, particularly if it's a medication. And then there are specific therapies for the underlying cause, of course, which can be numerous, but the mainstay, of course, is anticoagulation. Some cases we refer to INR only since 2021. There have been some newer techniques about stenting. They used to do it in the past, it was a bad idea. They've revisited some of the techniques for that, for thrombolizing and also for clot retrieving in the venous system, but we'll still have it in italics because it's only in specific cases and it's still jury out as to which patients it would be best for. So then, case 2, 23-year-old woman came to the emergency department with a severe headache. Why? Because she saw on TV that she should. The 5th attack in the past 6 weeks, bilateral squeezing in character, 8 to 12 hours. She had neck pain and nausea. It wasn't made worse, or didn't really stop her doing her 1-hour physical activity. She denied any sensitivity to light or noise, and her exam was normal and imaging was normal. And she, at this stage, had a CT, but no MRI. So the big question is, her headache meets the criteria for which of the following? And of course, there are no red flags. So the big thing is that this is actually probable migraine. And why is that? Because migraine is an important one to remember, is still the top of your list. It is the most common reason they're coming in. Tension, they don't usually come to hospital. A tension headache will sit in a GP's practice and complain. They always get this headache, but they took some Panadol and went away. But why do they still have the headache? But migraine will rock up to A&E, particularly if the news has scared them into thinking every headache could be a catastrophic clot. And migraine is debilitating, but migraine also comes with, luckily, a few additional features that make you think, this does sound migrainous, which are photophobia, impairment, and nausea. And they have a high predictive value that it's migraine you're dealing with. And photophobia, obviously, it's the light, and light is not always that they squint, but light bothers them. Impairment, they feel head fogged. Anyone that's ever had a migraine, you do not feel normal. You can still work. It doesn't mean it stops them working, but they don't feel on their A game. And nausea, they often have nausea and they don't always vomit. And the other ones to also ask about are phonophobia and just plain irritation. Not the same irritation as a cluster where they're just really agitated, but they'll be irritated at the world. They want to basically be by themselves. And they will often say this as hallmarks of how they're feeling. Migraine can be 10 out of 10. I don't know who's had migraine in the audience, but if you have, you'll know that it can be really severe, and it can be severe as any of the other things we're going to talk about today. It is incredibly common. I will really just hammer home that it's one of the biggest neurological conditions, and it's genetic, and it's more than just a headache. It has neurological, sensory, autonomic, vestibular, cognitive, and gastro symptoms. And the gastrointestinal system, of course, has a nice neuroplexus wrapped around it and will respond to the same chemicals. So it is very important not to forget that the gut will be involved. It is the leading cause of disability under the age of 50, particularly in neurology. So I find that across all specialties, it's 6th worldwide, but you do not see it getting all the press on, you do not see it on TV campaigns, charity campaigns, but it really should get more press. The reason it doesn't, of course, is that up until more recent times, perhaps the population largely affected, aka women, weren't necessarily the driving forces for a lot of healthcare research and attention. And for many years, of course, you will know that this was thought of to be a women's hysteria. Turns out it's not. Turns out it's spreading cortical depolarization and activation of the CGRP pathway. But that's not quite what they thought, of course, in the last century. So it's only really now that we're throwing lots of money at the problem, getting more research and trying to upskill people in early recognition research and actually trying to reduce the burden of disease. The hypothesis, as I briefly mentioned, and busy slide on purpose, but the reason to bring it is actually to remind people that the old vascular thought back in the day, it was, oh, it's vascular, you're going to have a stroke, oh dear, don't give you too much XYZ. That's actually been thrown out the window. It's more of a cortical excitability, and as a result, the patient will have this aura, or not even an aura, but more of a feeling inside. And then they will get this secondary depolarization, activation of CN5, and then vasodilation, inflammation, sensitization, and the CGRP pathway. And it's important because there is so much involved in migraine, and the migraine patients will throw in so many symptoms. I felt like this, and I got tingling this, but that's because it's a whole brain problem. It's not just a pain. It's actually a neurological syndrome. These are the two main things that we should categorize each patient into: aura, no aura. And within those, of course, without aura, you get your somicogenics, you can still have different areas involved. And with aura, of course, there's visual, sensory, motor, brainstem, vestibular, lots of different features. And hemiplegic is different than motor. Hemiplegic is rare, motor is common. Now, this is classic. They have this early premonition and or aura, but patients will just know. They'll say, I know I'm going to get one. I just know I'm going to get one. Because they will have this thing beforehand, often they actually have fluid retention, eating lots of salt, craving, yawning. They just don't feel themselves or really fatigued. Then the aura, if they get aura. But remember, migraine without aura patients, just the only difference here, they might not actually get the aura, but they'll get the rest. Then they get the headache, and that's the bit they come to hospital with because they can't get rid of that bit, but it's not necessarily the most disabling. then they usually have a bit of a hangover effect, and then it slowly goes away. And the big key is to treat it, but also to identify the things pre and post that are leading to its onset, because you can't just fix it with medication alone. And it's important that these are not forgotten. Vestibular, sensory, motor, and visual. A lot of patients have a typical migraine, but it's not actually atypical. It's just the different aura. And it's important to go through with patients that it's still aura, but the headache will be less, of course, in vestibular, because that part of the brain, obviously there's not as many pain areas, so it'll be more dizziness, less headache. Whereas motor, of course, that's very frontal area. They'll have a lot of headache and the weakness with it. So it's important to actually educate the patients on what they can expect, so that they don't rock up to ED every single time, but then, of course, just get codeine and kicked out the door, because that helps nobody. So is it a migraine? This sounds obvious, but it's not well done in hospital. And you'll all be nodding, I'm sure, because it is not well done in hospital. And it is definitely not well done in A&E, because they don't have the time to go through all of these features, and neither do most people in standard general practice. This can take an hour to sit with the patient on the first visit, and even beforehand, to go through onset, duration, character, all the different features. We even send patients questionnaires beforehand to really get a feature of all of these things, because this is a really lengthy discussion, particularly the first time. And then this is crucial. We all carry these smartphones, and yet no one's putting them even just in the diaries. They all estimate it's a bit better, it's a bit worse. But if we get them to quantify both the severity and the days they use drugs and the days they have headaches, it can actually really change how we approach their treatment. But despite the fact we have all the technology in the world to do this, pen and paper seems to be the way most patients successfully do it. However they want to do it, it's important to get some form of a headache diary, whether it's in headache clinic, GP practice, or just the patient sitting at home. The medical history is really crucial, not just for the things that could be comorbid, but also because of unfortunately, our treatments can have a lot of positive effects, like an anti-epileptic can treat 2 conditions, but also quite a negative effect. And as you'll know, a lot of the migraine preparations can make people more anxious. They can make people gain weight. So it's really important to really know about what the patient would want, because it's very trial and error, that next step, but it's very important to individualize, not just to the headache phenomenology, but also to the patient. And then this is really obvious, but I feel like I have to tell my interns and registrars this every day. So it's important to always put it in presentations. And it's something that is always important to have a look at. And even patients themselves can examine this on telemedicine, and we get them, and we even send them pictures of what they need to point at and show them, because we need to see what their facet joints are like, meningeal irritation, do they have any signs of GCA? But then for things like papilloedema, we always like to see them face to face. But if you can't, and I appreciate some patients are quarantining or some patients are in naughty LGAs, then we would say, why not go to an optometrist and have a quick eye review in your local area if you don't feel comfortable coming to clinic? Because that's a really important thing, because migraine can be phenomenology of things like IIH. And again, I'm going to throw this in there, because do not ignore red flags. Even if migraine is still the most common cause of all of these, you still can't ignore them. And it's important to always, if they don't look sick, you can just refer to clinic, get a scan. And you can order a scan, as you know, in general practice for new onset headache or new onset neurological signs concerning of brain tumors and for epilepsy. And you can directly order an MRI if you think that's important. And likewise, you can even refer to clinic. It wouldn't be something I would call tensional migraine if any of these appear. The investigations are obvious, except CSF is not done enough. Full stop. It does need to get done, because you need to exclude some of the chronic meningitis, cancers, but raised pressure. And we are not a diminishing size race. We tend to be getting fatter and fatter. COVID hasn't helped any of us. So the reality is IIH is just as common, if not more common, and it's often missed because the patient doesn't necessarily have those classic signs, and it's presenting more like a migraine. And then those that are often not included are iron studies, that because patients will often have low iron exacerbating their migraines, but not have iron deficiency anemia. But iron studies still need to be done, particularly in young women with menstrual losses. It's not actually accommodated for a lot of the time. And thyroid function tests, that's the other way that a headache can early present, of course. And I added these in not to go through them all, but I think it's nice for everyone to have a copy of all the different things used in acute therapy, and also to realize what's not on there. And you won't see any opiates. Why? Because they're useless. Sure, the patient might tell you it makes them feel better and then they can go to sleep. I have no doubt. But does it help the migraine? Absolutely not. So why they're being dished out in A&E? Why are we giving them the ward? There is no role for this. And particularly when we have so many of these other things at our disposal, including the triptans. And the triptans we have, as you know, rizatriptan, which is the weakest. So if the patient said it didn't really work, doesn't mean triptans don't. That's your weakest. So upgrade to sumatriptan, elatriptan, naratriptan, Zolmig. We have all these different things available to us in Australia. And it's important to actually upgrade. And if the patient's saying they're not strong enough, they don't last long enough, try a different one. And the big last three, so caffeine, readily accessible, whether it's no dose or coffee, but most migraineurs will be afraid to tell you they like coffee when they've got bad headache days, because they read in the headache histories, do you drink too much coffee? But we all know too much coffee is about 10 cups a day plus. Why? Because if we don't drink that much, it can't be too much. But the reality is caffeine helps migraine, particularly if they're not caffeine addicted. So it really reins in on the headache and is good in combination with dissolvable aspirin and antiemetics. And the antiemetics we give not for the nausea. They are anti-nausea tablets, but we couple them with things because of the dopamine blockade or the serotonin effect. And that's why we give them to patients, not because of nausea. Lasmiditan, watch that space for next year, but that's going to be very exciting acute therapy, but not available yet thanks to COVID. And when they go to hospital, if any of you are working in any of the shifts lately, again, triptans, they're all there, antiemetics, even the antidopamine ones, which droperidol, chlorpromazine, yes, old-fashioned, but I suppose tried and true, not opiates at all. And limited evidence for some of these, but you'll see us use them. And it's usually because the patients failed the others, or that we're actually know the patient well and they respond well to certain things. But steroids particularly, we really just reserve these for very rarely and in patients we know that come to the tertiary headache clinic. No. Opiates are bad. And it's not because I think every patient's going to be addicted, but would you give an antibiotic to a viral infection? It's the same principle. And unfortunately, the same problems occur because opiates lead to medication overuse headache, but opiates also don't treat migraine. So you're treating the wrong thing with the wrong drug. Now, the migraine acute management plan, we often give patients in migraine clinic, of course. So we often give them their own plan of what to do, including what to do in hospital, an examination of a busy one. And I just put this example in because this is one of the hospital ones that some of our patients get. Then it gives with what they need, what they get. If it's this, what do we give? If it's that, what do we give? And so the patients know this. They also have a copy of this. And we then highlight for the patient which ones they've done well with in the past. And the patients then, when they come, or if they're a routine tertiary headache patient, then they actually circle which ones do they have red flags. And these are also in the A&Es and have a step-by-step of what to look for and what to treat headache with. And they've come out in fashion, of course, lately, because, of course, some other causes of headache have appeared in 2020 and 2021, but there's an overlap with treating the phenomenology. And the triptans, I've included this for you to remind you of the hours, that the half-life and the onset, because it's important when someone tells you, oh, my headache comes on slowly, or it goes from 0 to 10 quite quickly, to really tailor the triptan to them. And there's not just max salt. And I don't know why, but in Australia, every single time I see a patient, all they say is that they've tried max salt. But it is not the only triptan available. And it's a good one, particularly if someone's got a lot of nausea, because it comes as a wafer. But we have a lot of other options. And I haven't included the injectable one, but a lot of patients will be given that as well, of course, so they don't have to come to the A&E department. And then it gets more exciting. So these are the triptans, but I like this slide because now we get to see number 2 and number 1 is the CGRPs and the GPANs. So as we go into it, these next things will overlap. So the big problem with the triptans, poorly controlled blood pressure. It's going to be a problem because they're going to act on areas where the blood vessels will constrict. It's a warm, fuzzy feeling the patients will tell you they get when they take their triptan. If they've got kidney impairment or hepatic impairment, you'll notice we don't use it. We don't use them in pregnancy. When we use MAO inhibitors, that's in really high doses. Of course, some patients might be on low doses, and low doses of anything is probably safe together. Serotonin syndrome can occur when combined with SSRIs, but to be honest, that's if the patient's popping triptans. And the big key is that 2 doses, 2 days apart, 2 days a week, 2-2-2 rule, because it leads to a lot of medication overuse headache and is the forgotten one in our medication overuse talk. And the blocks, so don't underestimate the power of a greater occipital nerve block. The good bit is that patients then, I am absolutely sure a lot of placebo with this, but never mind. You can have steroid and lignocaine and actually numb the occipital nerve. Now that can treat cervicogenic, occipital neuralgia, migraine, autonomic hemicranias, the lot, because of course blocks are actually just numbing the problem, and the steroid isn't actually the main problem, the main benefit. It's local anesthetic, and there's actually anesthetic alone was shown to be as good as steroid combination. So this is something GPs in England do in clinic, because in the greater occipital nerve region, which is safe, easily done in clinic, you can do it even just with local, even if you don't have depomedrol. And the SPG blocks and the trigeminal ganglion blocks and the supraorbital blocks we could do in hospital, or we do in A&E, but greater and suboccipital blocks are often done in clinic, on bedside, or ultimately radiology. And they're fantastic ways to abort something without medication, particularly in a neuralgic patient or a cervical patient. Medication overuse headache is a big problem. A big problem because patients find it very hard to get off these therapies. And we're trying to change our packaging this year so that when they go and buy a pack of Nurofen, this is a big warning, and same as Panadol, same as the triptans and codeine. It's become better since codeine was harder for them to access, but the big thing is to limit opiates, triptans, paracetamol, Nurofen, to no more than 2 times a week on average. And the overuse is not immediately. So a lot of them get worried if they've had a broken arm that they shouldn't be using these things too much for their broken arm. It is of course not that. It's about using it for greater than 3 months and using too many times, but it's an average. So some patients might have 5 days of a menstrual migraine. That's okay to use 5 days then, because assumedly the rest, they wouldn't actually have any. So you have to stop all those things. Now that's where your resistance will come. They have to try and stop it for 2 weeks and then slowly reintroduce them. And the other key is to try and consider early CGRP introduction. And now they're on PBS, it's something to raise in this discussion, because the CGRPs are shown to reduce medication overuse headache as well as migraine. And it's important then to start those up while the patient's getting off their things. Try and set it a short-term pain, long-term gain, but it is very difficult to get them off it. And prophylactic therapy, all patients will need if they get greater than 1 attack a week, particularly if severe, or if they're actually find that they're at an increased risk of these disabling headaches. But lifestyle changes are the thing we don't often address. Now, you can't just address lifestyle changes, though, or you won't actually get the trust of the patient quite rightly. But sleep is the big thing. And actually in the pandemic also positioning at their laptop and not having too much screen time. But sleep, and good quality sleep, not just being in bed, because we've seen a lot of telemed done by patients in their bed. It's not about being in bed. It's actually about restful sleep. Natural therapies are actually indicated, and even A&E dish these out, because the reality is patients have a lot more faith in natural therapies than they do in drugs. That's fairly universal, but these are proven at certain doses. So it's important not to underdose them. And compounding chemists is probably the cheapest way of getting the proper doses here. But if patients are keen to start this, then this is actually where you should head and actually give them the effective doses that we would see actually work in the studies. Not CBD. CBD actually increases migraine and increases medication overuse headache. Great for other pains, but not for this. This is a busy slide. This is to help you day to day. These are basically we have these in clinic and patients have access to these as well. And these are the levels of evidence with the actual drugs. And these are the drugs we use in migraine, the fairly standard ones. However, just because the evidence is lower doesn't mean it won't work for that patient. So we often try with things like amitriptyline, Botox, propranolol, Tofamax, Candesartan first line. And of course, Botox not immediately first line, PBS, I've got to fail a few others. But then we also have, of course, these others with lower evidence that are actually very effective. The standard migraines, things like that, we don't hear of that anymore, quite rightly, because they just make women fat and sleepy. But the reality is you'll still hear a patient say that that was something that helped them. I'd still look away from that because the side effects of them are quite bad when you've got so many other things available. But a lot of patients, of course, will say, oh, I used to like this drug. And of course, it's up to the individual patient. So this 2020 saw a few changes in the world. And a few were good and a few were bad, but some were good. And this is the good. In June of this year, the CGRPs the first two hit the market for PBS, and next year more to come. And the advantage is we have a competitor and the first one in the market that was designed for migraine. These can be given in A&E, these can be given in GP offices. Yes, per PBS at the moment, a neurologist has to oversee the initiation, but they don't have to continue it. So it can be something where you're like, yep, do you agree? Yep, I agree. And GPs in rural areas particularly dish these out more freely because patients can't access Botox as easily, but patients find this fantastic game changer. And the mechanism of action is not the inside bit. So warn the patient, this won't stop aura. They might still get flashing lights, but this will stop the secondary problem, the pain, and then that hangover and the other focus. And it's really good to have these three in the market, with more coming next year. The two on PBS you'll see are Adjuvy and Emgality, but all of these can be accessed privately if you have a patient that doesn't meet the current PBS criteria. And the patients do continue to actually access these privately, particularly coupled with Botox, which they might get on PBS. And again, we would say, it's often not known by GPs when we've presented this before, that GPs can actually access those privately without neurologist help. They don't need that if they think it's the right drug for the patient. And things like cluster headache, patients like that privately, of course, because there's a lot of evidence for Emgality and Adjuvy and cluster, but it's not yet a PBS indication. Some patients also do get benefit from coupling CGRP and Botox, but again, PBS restricts you using both at the same time. It's more of a one or the other, but the patient might really do well with both. The contraindications for these: pregnancy, number one, lack of data, and you'd actually need to have a washout of at least 3 half lungs. Breastfeeding, ditto, no data. Ischemic heart disease, we used to worry, but actually we've been using these around the world for a while and it looks reasonably safe. The problem is allergies, obviously, and really poorly controlled blood pressure, same as the triptans. But it's very good in people who have post-craniotomy migraine, fibromyalgia, medication overuse, chronic pain, because the way it works. So these drugs, yes, designed for migraine, but actually will have a lot more benefits. And the PBS criteria is exactly the same as Botox. So the good bit is it's not a surprise. It's literally the 15 days of headache per month, which is chronic, versus acute, which is less. And then patients had to have experience and adequate response to 3 medications and the 3 conventional migraine medications. But in some patients' case, obviously that includes their past medications. Botox, to quickly remind everyone, it's 155 units. So if the patient is paying for that privately, that could be a lot of money, but it's on PBS, of course, and it's every 3 months at 155 units, plus or minus, because they actually, of course, get 200 units per PBS. So we then can later on look to whether we do some of their pressure areas or other things with it, depending on the patient, because they do own those 2 vials, but this is your standard protocol for migraine. They have to be 18 years or older, technically, for PBS, even though there would be a benefit in the younger age group, but we have to obviously work with what we've got, because that could be very expensive otherwise, if you think of the cost per unit in the private or cosmetic world. And these are the sites we put it. And of course, it makes sense. It's in areas where there'll be muscle tension as a result of this CGRP pathway and activation of the nerves. It won't treat the aura, same as CGRP. So we often combine these 2 medications with others, and you won't be surprised the patient's like, oh, well, that one's for my aura and this is for my headache. And we divide them up with the patient so that when they're doing their headache scoring, they're actually scoring each of them differently. And the what drug first is really crucial, because patient preference actually really weighs in on this. Always ask them priorities, preferences, burden of illness, severity. Are they someone who's medication sensitive? Are they more into vitamins? Or are they like, hit me hard, I want needles? And it's often very important also where they live. Do they have access to it? And of course, a lot of places that do Botox, we have public Botox, but the majority is privately done, and that can cost a lot. So that it's not so much the PBS charge, but of course an injectable charge. And think about the migraine type. So I put these in the notes for you more so because this is often a common question we get with the what's vestibular. So what works better in this one? So psychogenic, what works better in this one? And there is a trend in each different type as to which one we would think about first. And this is not an exclusive list. This is more, what would you think about first list? And certainly there are up to 20 different agents. So this is not an exhaustive list. And this is the main thing that the patients want to know. What's it going to do to me? The big one that people forget is sexual dysfunction. So sedation and weight gain patients ask me before I've even had a chance to talk. Anxiety, Topamax, of course, is a big one that increases that. And pregnancy planning, we obviously want to avoid Topamax, valproate, things like that. But the big thing that people don't raise because they haven't even thought about it is sexual dysfunction. And the most common reason to stop propranolol is sexual dysfunction, and in women too. So it's really a crucial thing to raise with patients as to what really would matter to them, because some patients actually wouldn't care about that, others would. And side effects can be good. So manipulating the drugs can be really helpful because, of course, Topamax helps obesity and amitriptyline can help insomnia, and so on. Medication plans start low, go up slowly. And I put this in because most people who fail medication, it's because they didn't start slow, go up slowly. They just started slow and sat there, or they were thrown at a high dose early on and hated the drug. And after 12 weeks review, and then if it doesn't work, don't persist, because that'll just stop the patient being compliant or stop their faith in their plan. And at reviews, you just make sure cost, fast pain relief, return to normal function, but the usual things, and this, of course, but they still don't do it. A number of times we see a patient and they're like, oh, I forgot, even though their phone is never more than a centimeter from their hand. Take-home messages need to be the medication overuse and the treat the phenotype, because secondary migraine is common. Secondary comes with IIH, comes with brain tumors. When you're talking to them, you know they had IIH, but the pressure's now normal, but they have a migraine phenomenology. So you treat the phenotype. Migraine is not, you're not going to hurt the patient by treating the bitemporal throbbing headache. It's worse at nighttime with amitriptyline, even if you know that the underlying diagnosis is something else, because the reality is you found the underlying diagnosis and you're treating that as well. So the importance is that treating the phenotype, because the migraine phenotype and secondary migraine overlaps a lot. And I bring that up right in time to do one of my favorite cases. And we've had 5 of this kind of patient referred today on my on-call alone. 49-year-old woman presents with a global headache, fatigue, non-specific tingling, and fatigues twice. Felt short of breath, but was still able to walk for an hour a day, very specific that she only went for an hour, and was restricted only by her current lockdown orders. She had to miss a whole day of work because she had fatigue and headache and had her AstraZeneca vaccine 5 days ago, and that's why she's in A&E, of course. Her only regular medication was candesartan. The headache was global, persistent, according to her, but of course went away when she did some exercise. Was no focal neurology. It did not wake her from sleep. It was not worse with movement. It just was sort of there. It came on gradually, but it was a bad headache. It has not improved with Panadol, but she hasn't even tried Nurofen or aspirin because even though she was offered them, she was afraid of using them with the AstraZeneca vaccine being the recent thing she'd had. Her bloods were all within normal limit, and that of course included D-dimer. She looks tired, but was otherwise comfortable at rest. She had a formal neurological examination, completely normal, and was COVID swab negative. So the diagnosis was headache. Her diagnosis is a side effect of her vaccine. It is not a scary side effect, and we spend a lot of time counseling patients about the reality of what is expected for the 2 available COVID vaccines in Australia at the moment. So this is your expected side effects. Dear patient, here is your injection. Maybe you'll get nothing, but why don't you have this list? Because perhaps you'll get any of these things. With AstraZeneca, it will be worse the first time, better the second, and vice versa. For Pfizer, it will be fine first time, maybe terrible the second time. But please note, headache rates very highly on the list of side effects, and I'm surprised the number of patients that come in looking baffled that this could have happened and not be a clot. So then let's get on to what the patients are all worried about. So there's obviously the AstraZeneca vaccine is an adenoviral vector vaccination. We spend a lot of time sort of trying to reassure patients it's not actually adenovirus that affects humans. It's obviously an adenovirus that affects the simian population. So you don't actually get infected by it as such, but it excites an immune response. And as a result, you can very rarely get a secondary problem called TTS or VITT, which is basically an increased consumption of platelets, very similar to the heparin-induced situation, but also an increased clotting related to it because of a defective clot. So the problem, of course, is that this has reached the press, and a lot of patients are very scared of this. Bypass me, bypass the GP, and straight into A&E with this fear. Vaccine-related TTS, yes, you can get the CVST, but thrombosis of the splanchnic circulation, PE, DVT, arterial thrombosis, and cytopenia are also very important classic features. And of course, a lot of patients haven't come in with the top one. They've come in with shortness of breath, PEs, and that's actually been a more common presentation of vaccine TTS, fortunately, because CVST is very serious. The comparison of thrombo events is really important. So the Johnson & Johnson and the Oxford ones were compared to each other. And the big thing with all of these is to remember that they all come on around the 5 to 24 days. But a big problem with all of this, of course, was low platelets. And they did have features on their bloods alone of an abnormality. They were not just unprovoked clots. And they occur with a reduced platelet count. They occur after the first vaccine, and reassure patients you're not going to get it with the second. It's sort of a rate-limiting disaster if it's going to happen. And it does not occur less than 4 days, but they will still get a headache less than 4 days following vaccination. And they're found 5 to 28 days following vaccination, mostly in the 7 to 14 days. But they have red flags. It can be shortness of breath, it can be leg swelling, but they've got neurological red flags. It's not just a simple headache. Related to the AstraZeneca vaccine, with this one, of course, the big thing is also to remember back to the cerebral venous sinus thrombosis case I mentioned before. The big thing is that altered level of consciousness, seizure, neurological signs, and signs of rage pressure are really important. And investigations are key. And these we tell patients, you should just get this done first step in clinic or with your GP. If you don't have these big red flags, if it's just a headache, if you're worried, then the actual protocol, of course, is to start with the blood test, because if they're fine, the chances are it's just a headache and it's still related to the actual vaccine. And most of these are presenting in the first 7 days, which still fits for vaccine side effects. Yes, it's more likely early on, but it's not impossible given adenovirus itself. And if anyone's ever had adenovirus, it's a whopping great headache that virus gives you in the first place. So though there is a nice way of stratifying, of course, but the practicality is low platelets and fibrinogen and D-dimer, because if they're normal, you can pat the patient on the head. And if they have red flags, the patient should already be in ED. But the red flag should not be that it's a headache and it's 10 o'clock at night. The red flag should be, of course, postural, fever, tingling, like that cerebral venous sinus thrombosis patient. So then we'll go through this one quickly, but this comes back to an original one we presented, a 25-year-old with a previous history of IAH, managed with rate reduction and Topamax. The last lumbar puncture showed normal pressure. They've come in with a severe throbbing headaches. They keep getting these. They don't wake from sleep, but they're really bad. And what is the diagnosis? Migraine. And so this is a very common presentation, but it's an important one to treat the phenomenology. And often the patients develop migraine and the migraine continues even after it's normalized. Treat the phenotype is important. And this one is the last one, but is actually a very common-ish presentation. 42-year-old woman with a severe onset global headache, low-grade fever and night sweats, LP and MRI normal, CTA normal. The blood showed a mild elevation of lymphocytes and CRP. She had a severe global headache, waking up from sleep with no relief, neck stiffness, but no meningism as such. It had fatigue and a mild sniffle, but only with questioning. No sick contact she was aware of, no personal regional travel, no medications regularly, lives with a husband and 2 children, no drug use, non-smoker. Oh, but then when we said no sick contacts, well, not actually sick, but I guess her mother was diagnosed with coronavirus and did have some, association with the family, but her mum wasn't actually sick. The family was socially distancing already. She didn't actually present earlier because she said, but I have normal sense of smell. I just have the sniffles. I don't have a cold. My kids are in daycare. I just got another cough, sneeze. She was positive, of course, for COVID, started on NDEP and other simple analgesia, had fluids, and we followed her up over an 8-week course and then continued just to check in on her. And she's got 1 dose of the vaccination, but no ongoing symptoms, fortunately, at 12 weeks. So coronavirus. So this is actually something that's quite important to bring up because a lot of the patients that are, oh my gosh, my AstraZeneca headache, actually going through the history, like, wait, so why are you in hotel quarantine? Why are you at home at the moment? Because when we go through it, a lot of these patients do have headache, it's true, but a lot of them actually have had recent exposure to COVID. And one of the key presenting symptoms of COVID, up to 50% in Delta, but 34% on average, the 2 years, is headache. And it's a lot more, if you have a look at the statistics, than a lot of the things the patients are told about. This sore throat, what's that? Headache, very common. And they present to the GP. And of course, they rock up with a headache and they've not thought about the rest because there's no fever. And of course, it seems like all the patients go, my smell's good. But if you have a look, that's less than 10% of patients and even less in 2021. So it's an important way to end because don't forget COVID. In all the flurry of the AstraZeneca fears, everyone seems to have forgotten one of the bigger potential causes of headache that's walking into people's offices and is potentially walking out, leaving a little bit of a lasting memory for everybody. And if in doubt, so remember with cancer patients, headache patients, you can call through and there are GP direct lines for anything to do with cancer patients. It can be across Australia to get advice from people and to get direct assistance with patients, particularly anyone with any diagnosis of cancer, suspected cancer. And it doesn't really matter where they are, they can help with rural patients, but it is important because particularly in COVID times, it's very difficult to access a lot of other hospitals. And it's important to then at least have direct access to advice. So, questions?
Thank you so much, Julia. That was an incredibly comprehensive coverage of a very complex area, and really lovely topic all about the impact of the headaches from the coronavirus itself, let alone the vaccine. Very topical. Thank you so much. So we've got a couple of questions. First one was, are there any tests that we can do prior to starting treatment? I think this is in cancer patients to identify which patients might have adverse outcomes.
That's a very good question. So in patients that already have an autoimmunity, for instance, and you're looking to start the immunotherapy or other things, if you already know they have a paraneoplastic condition or a particularly bad autoimmune condition, this can unfortunately be predictive that they're going to get worse, but it's not necessarily a barrier to the treatment. So it would be something where we'd then assess whether we can treat both things, treat one, then treat the other. But it is something reasonable to bring up, particularly in patients with another severe form of an autoimmune condition, or if they've presented with something that could be exacerbated, like a paraneoplastic or NMDA. Hopefully things like that have already been controlled beforehand, but it is very important to bring up. And the other one that's often forgotten, again rare, is the optic neuritis. So things like NMO and MOG, again rare, but of course that's off the eyes a forgotten area, but can be catastrophic. And it may be something we've all forgotten to ask the patient about. And the heart, and a lot of the time the heart's somewhere to focus on.
Thank you. The other question was really clarifying the when we're looking at the symptoms of headache.
Yeah.
Headaches, intermittent headaches that actually get worse with movement. What should I think of?
So lots of different ones, of course. The first thing would always be, if assumedly CT normal, because of course I guess any movement you think, okay, got to exclude tumor. But the reality is that cervicogenic headache particularly, and also the pressure headache, so things like cough, headache, can actually present with any form of Valsalva, obviously with sometime with movement, and patients aren't always aware that they might be slightly breath holding as well, or a little bit breathless because they're not the most fit. But cervicogenic would be high on the list, and particularly in the pandemic, work from home, I don't think people have actually thought about just getting up and going for a walk. They're in their own home, but they're at the desk, they're not getting up, whereas maybe that social interaction had us all walking around chit-chatting a bit more. And that's a really key thing that we're seeing a lot more of this year. And particularly when they're out jogging and stuff, they start noticing this pain at the back that wraps around, then they get the tensions and tinnitus, and that area is exacerbated, but it's actually primarily from C1 to C3 in their neck, leading to a secondary headache. Very common, unfortunately, but the cough headache, we call it cough headache, but of course, cough, sneeze, Valsalva headache is probably more accurate. That can actually be brought on too by someone doing their exercise and the breathing that they're doing to do it.
Mm-hmm. Lovely, which actually brings us to the next question, was tinnitus. How does the symptom of tinnitus fit in with headaches?
Oh, in lots of ways. Gosh, I could have a whole lecture on this one. Depends on the headache. So of course, the cervicotrigeminal pathway, which gets activated back to front, so wrapping C1 to 3, you actually have some vagal but also ear innervation. So if it's a cervicogenic occipital base, they'll often tell you, I've also got tinnitus. But then of course, migraine can too, through that spreading activation within inside the brain, which then leads to autonomic as well as auditory activation. So they can then hear not usually pulsatile tinnitus. Of course, that one always need to exclude it being something else, but it's often a whooshing, a low level thing, but often they will swear it's all in here, but they can still feel it in their ears. And vestibular headache, it's almost par for the course, that they're dizzy and they'll also have hearing issues.
Mm-hmm. Thank you. And just some clarity around cluster headaches and really whether they fit under the migraine variant, or is there a different pathophysiology for those?
A sensible question, different pathophysiology, but because it's a primary CGRP problem. So it's coming primarily from not from a secondary activation of CGRP. Where it's activating, back or front, is currently up for debate, but it's a primary headache disorder, and it's separate. All the autonomic aphalgias and those are separate because they're being a direct access of the CGRP. However, it's actually then why those things will actually help. Whereas migraine is a secondary activation, an inside-out problem, as we would say.
Fantastic. Thank you for that. We've actually got enough time for a couple more questions if anyone wants to pop them into the question box there. Whilst you're doing that, I might just really quickly, while we're waiting for any more questions, just to mention that there is actually quite a bit of work being done in this area in the health pathways. I'm from Sydney Health Pathways, but there are other health pathways in other areas. So for anyone who isn't familiar, the Sydney Health Pathway username is connected and the password is healthcare. And we actually do have, of course, a lot of information that is constantly being updated on that on the COVID and on TTS, those sorts of issues. That is all the guidelines for that that is being done all the time. Plus, I've actually got some pathways, particularly around headache, and hopefully that a lot of the things that you've said tonight, we've actually listed them there, such as the migraine, migrainous treatments. So hopefully a lot of that is actually there, and certainly the red flag. So thank you for that. Any other questions? I would have thought there'd be lots more questions coming through tonight. What causes the nausea in migraine?
Can be different things. So one cause in some patients is actually gastroparesis, because the abdomen and the stomach also get affected by it. So some patients, particularly when they're vomiting up a storm, it's there. Others, it's actually in the floor of the fourth ventricle with the more brainstem autonomic exacerbation, particularly those with migraine with aura. And so whatever the aura is, they often get that autonomic activation, and then they also get it. And they're particularly good with ondansetron, whereas those with the gastroparetic, you're particularly good with dopamine, just sort of two things, one benefit. And so then we give them things like Maxilon. In other patients, it's actually disequilibrium. So for vestibular patients, I just tell you there's a sensation that they're always car sick. And it's because there is this disequilibrium that they really feel terrible about. And they will do well again with a more central approach, like on Dansitron, because the disequilibrium is more central and stuff like Semitol won't help. And they'll tend to find that would work better at a more central level. But a lot of migraine patients will just tell you there's this low-level dizziness that they can't really explain, but it's more like permanent car sickness.
Sounds horrible. Just a question around treating the prodrome prior to the aura. So you were mentioning about the different that you can treat the aura separately. Can you tell us a bit more about that?
Yes, so the auras, of visual aura, things like this, some patients, of course, one drug, one problem. So they'll have things like Epilim, Topamax treating both, but other patients, so Botox, CGRP, they will only really help with the pain part of it. So then we would add in a second one like amitriptyline or something that would affect sodium channels and that spreading depolarization to actually reduce the aura itself. And these drugs we also would use, the same the antiepileptics, in the patients with aura without headache. And of course, then we're actually, again, subtyping these patients to, again, a different treatment, because there's no point giving them an anti-headache drug. All they're worried about is their actual aura.
Thank you. We've got a question about children, and is there any problem giving B2 to children? Is it not as effective, or are there any other issues around that?
No, but with pediatric headaches, the B2 is fine to give. It's just the doses of a lot of these non-pharmaceuticals haven't been fully studied. But to be honest, the ones you can buy over the counter in Australia are probably very safe, but for that reason, you wouldn't actually get 400 milligram tablets. They would get compounded, or people access them from things like iHerb. Melatonin's been well studied in kids. There'd be no problem giving something like riboflavin, and we certainly do use in urine a sort of low dose B2. But in children, a lot of things just aren't studied as much. Of course, that can go with a lot of things. And in kids, often migraine presents more abdominally for the first part of their life. Lots of vague tummy pains and colic and things like that. And then the headache pathways are more mature. So a lot of patients, the headache isn't a thing until teenage life. And then that nicely overlaps, of course, with more adult treatments. You could use it, of course, but the actual doses will change and the amounts. But then they have pediatric style vitamins instead.
And then just a question about, are you seeing cases of functional neurological disorder associated with COVID vaccinations?
Yes. Many. Many. The number of patients that think they're having a stroke, think they're weak, odd movement disorders, but I guess it's not hugely unexpected. The most of them, though, to be honest, with bloods and scans have been well reassured. I haven't found too many patients have sat in the emergency without listening. They've just wanted to know what it isn't. But the problem is they really are clogging up the already COVID-riddled ANEs. So they're only going to be sitting right next to a COVID patient. And it's a lot of these patients, you really don't know why they haven't contacted their GP or contacted us or someone else first, because they're not that unwell. I'll be frank, they might have a headache and they might have some mild flu-like symptoms, but they haven't taken a scrap and they really don't look that sick. And they've often bypassed all the very sensible mechanisms we've all put in place and rushed straight to A&E and sat right next to a COVID patient for 12 hours.
That's very true. It certainly happened to a patient of mine, exactly that. So again, are you talking about the giving more information with the vaccination so they know what to expect and how to manage that?
All of us probably need to do that. The media certainly, but all of us probably need to. And when we give these medicines and when we're giving the vaccination, I think patients haven't really known what to expect. And a lot of fear, particularly with the AstraZeneca in the young patients, because they've sat down and they've been told a million things and been told you can't sue me if anything happens. So then they're just chewing their nails for hours. And we really do then have to really rein in on their fear and go, it's okay, the chances are you don't have any of those things. And so it's a lot of fear, unfortunately, that's probably largely unjustified, but that's all right. The media, unfortunately, has led to a lot of it in order to sell papers. We can't really blame the media for doing what it's done for centuries, but it's about us all at a level, probably educating patients better, but also the obvious to them and say, don't rush to A&E unless there's something that you would have rushed there anyway. And if you didn't know AstraZeneca was a problem, would you have gone to A&E with this headache? Because if not, why didn't you start with the GP? It's fine to start there. They may still send you in. But the reality is, why not start with us, them, anybody else? And they're not getting that message. And we've even said to patients, they're like, oh, I just thought I have to come here. The media said, I'm going to die. It's a big catastrophic issue. But no one else is telling them anything opposite, particularly in the big vaccine hubs. So we all probably have to get the message of, look, it's okay. Is it really serious? Would you have gone if you didn't have the vaccination? Would you have just gone to the GP instead and actually talk through this instead?
I've certainly been having patients telling me that you're apparently not allowed to take simple analgesics like ibuprofen or paracetamol after a vaccination because it's blunting the immune response. So that's out there somewhere in social media that we shouldn't there. So they're not taking anything either. So I don't know. Yeah. One of the other questions was around trigeminal neuralgia. And is there any evidence about Epstein-Barr virus and trigeminal neuralgia?
Not EBV, but VZV. So trigeminal neuralgia, when it's not due to a contact of the nerve, there is quite a reasonable evidence that there could be, just like Bell's palsy, actually activation from VZV, but not so much EBV. The way EBV actually works and its version of neurotropy doesn't tend to reactivate in the nerves as much, whereas VZV, shingles virus, that thing's every second day causing Bell's palsy, trigeminal neuralgia, typical facial pain, super common. And so the problem is if you don't see it doing it, it's already probably come and gone. So there's no point with antivirals, but nerves just don't like being touched. They really don't. And so then if there's no contact, that's why medications are needed, because there's no point sticking Teflon when there's no neurovascular compromise. And the key is then to just reduce the nerve's pain and eventually it will switch off.
Getting close to the end, but there's a couple more questions coming through. One is really about the D-dimer test. It's very specific and reliable to be done. Sorry, I'm sure I'll reframe that. Is D-dimer a very specific and reliable test to be done in our practice when you've got a suspicion of AstraZeneca complications of TTF?
Yeah, look, on its own, no, of course. Like if you actually had any patient, any headache, no, but it's adding in, same as if you had a DVT-PE, it's pre-test probability. So if you have a headache that doesn't have the key red flags, that is just headache, let's say, so no arm weakness, no seizures, you then negative D-dimer and then negative fibrinogen and normal platelets would make you think this isn't a problem. Whereas if the patient had any red flags clinically, you don't have to necessarily do the bloods. I would say this 1,000 times. Don't hear these lectures and then you have a patient with an arm that doesn't move. You don't have to do this. They go straight to hospital, seizure, hospital, coma, hospital. Like you do, no, go straight in. But if it's someone who's just a persistent headache, they're not sure what to do, the pre-test probability, it's kind of like PE. They're on the fence. You need a bit more to do that next step. And the next step's imaging. The next step's not even A&E. And CT, of course, on the day we can all get, and not an MRI, as much as we love it. But the reality is this stuff can all be done as an outpatient. And it's not to reduce ED's burden. They would say, yes, it is. But COVID patients will be in A&E. Yeah. So the one key place to keep patients away of is the obvious place. And so we want patients to seek medical attention but come to all of us instead, so that they're not just sharing the germs.
So there's some really lovely practical suggestions there, Julia. There were more questions, but I think sadly we've run out of time. So I'd really like to thank you so much. It's been really